Hello, everyone. I appreciate the title of a doctor, but I'm not a doctor. So, beginning of October 2024, we started to screen for peripheral artery disease using the ankle brachial index. Sorry, my name is Jerusha Owusu-Barnie. I'm presenting for SUNY Upstate University Hospital. And this is the map of New York State. We are located in Syracuse, New York, specifically in Onondaga County, where you see the red star. And so beginning of October 2024 to June of 2025, we began to screen for peripheral artery disease using the ankle brachial index for patients over 50 years of age that came in to see a podiatrist at our Joslin Diabetes Center. And so you can see that most of our patient population is located in Onondaga County, where we are located. And so for our ABI screening, we went by the guidelines for the Society for Vascular Surgery and the American Podiatric Medical Association. And as we all know, there are risk factors associated with PAD that includes cardiovascular, metabolic, and demographics. As one develops PAD, there are complications associated with it, and that includes cardiovascular events, foot ulcers, and amputation. So we initiated a PDSA cycle. Our aim was to screen 50% of patients over 50 years of age in 6 to 12 months. And this project began on October 18th of 2024. For DO, we started to screen Dr. Landy, who's our podiatrist, the patients over 50 years of age. And for study up to November of 15th, 2024, we screened 61 patients out of 165 patients that we saw. Of those, 17 were referred to vascular, 10 declined to do the ABI testing, and 1 was already seeing a vascular doctor. For ACT, we created a smart phrase in our EPIC EMR, and we also tried to provide resources and training to staff to increase the ABI testing screening accuracy. So here's our fishbone diagram. For policies and procedures, we kind of didn't have a standardized process for the workflow. There was also inefficient documentation of scanned images into our EPIC EMR. For patients, we had a lot of patients that fell under the exclusion criteria, and so we are not able to screen as many patients as we wanted to. And we have also had the issue of equipment limitation, whereby we had limited vascular cuff sizes, and so that also limited us in screening more patients as we wanted to. For process, we kind of didn't have a standardized process for referral to vascular. So a year prior to acquiring the ABI machine, podiatrists was screening fewer patients than we could have. So after acquiring the ABI machine, we were able to screen 88 patients. So that was around about 400% increase in our referral to vascular. And we also had the issue of time constraints. Established patients had 20 minutes per the appointments, and newer patients were limited to 40 minutes per appointment. For provider and staff, they had an issue of just adjusting to this new workflow, and that was causing delays, and also just being able to troubleshoot the device. So here's a flow sheet in our EPIC EMR. We have a spot to select yes or no, whether the patient screened for the ABI or not. You can put in the date, you can put in whether the patient was referred to vascular, and then we also have a spot for the exclusion criteria. So when you look at the right-hand side, you can see the various options that you can pick from. You also have the option to add in a comment if you so wish. And then down to the bottom, you have a spot to enter in the ABI results. So here's a table that has those that were screened for ABI and those that did not screen for ABI. So overall, we were able to screen for 245 patients. Mostly the mean age was around 67 years of age. Most of them were non-Hispanic whites with type 2. Most of them had type 2 diabetes with notable obesity and smoking history. And this data also has information on those that were referred to vascular and then those that completed their vascular appointment. So overall, we were able to refer 88 patients. The mean age in years was 67, mostly males. 60% were non-Hispanic whites, 80% had type 2 diabetes, and the mean diabetes duration was 26 years. And then this table has information on those that screened for ABI and those that did not screen those that had PAD present and those that do not have PAD present after their vascular appointment. And so 18 of them were confirmed to have PAD, and older age was more associated with those that had PAD. Also, those that had PAD had higher A1C. The A1C value was 7.9% versus 7.3% for those that do not have PAD. And then mean diabetes duration in those that had PAD was 31 years versus 21 years with those that do not have PAD present. And that was statistically significant. And also, we had smoking history being more common in those that had PAD. And look who it is, lying over there. So lessons learned, we had limited vascular cuff sizes. We also realized that education was more important, especially for the staff that were doing the ABI testing, and that was to increase our screening accuracy. We also learned that in implementing flow sheets in Epic and also a scheduling template in Epic really efficiently worked with our clinic workflow. So challenges include exclusion criteria, whereby we had lots of patients falling under the exclusion criteria. So some of them were patients having an amputation, the inadequate cuff sizes, some patients having pain or edema, unable to lay flat, plastic allergy, shunt or fistula present, wheelchair bound, and having a wound present. We also realized that there was a high referral rate to vascular surgery, and also that made us question how cost-effective this approach was. And also, people living with diabetes tend to have arterial stiffness or calcifications within their arteries. And so once they do the ABI testing, they tend to have inaccurate ABI results. So for our next steps, we want to continue to investigate this result inaccuracy and also further investigate healthcare disparities in implementing this ABI testing, particularly in communities with high comorbidities like diabetes. So I would like to thank the team for their help and support with this project, and also to T1D Exchange for creating this platform for everyone to share their work and also learn from others. And on that note, I'm happy to take any questions.
Thank you. Great and very important topic.
Thanks for that talk, Jordan Ross, Med Peds Endocrinology in Memphis. You've challenged me to do a better job screening for PAD in my adult patients. One thing I was thinking, sometimes I just defer all surveillance for a new patient, lots of insulin dosing, say at your 2-month follow-up. Well, I can start adding this to the list and be time effective. Because as you said, that's a big, to unexpectedly add that into a clinic visit when you weren't prepared for it is possible, but saying at the 3-month visit when we're doing your urine and talking about your eyes and your foot exam, that's a very natural thing to add. Was there, I get you called it a challenge. I think that is the reality is you will find disease and you will refer to vascular surgery. Have you talked with their department yet about their experience with this increase in referrals because you've appropriately screened and found the disease?
Yes, we actually have talked about it, and we just want to look going forward, just want to look further into how we have been having such a high referral rate and, what the causes are, could be how the testing is being done or, something else. So that is something that we are interested in looking at because the referral rate is, kind of high. Yeah.
Other questions? Maybe I have a couple quick questions. So one is, as far as I know from the literature, that sensitivity of the ABI in diabetes patients specifically is very low. It's like 30-ish, 40-ish percentile. Specificity is very high. How do you address, so you probably for just generalized screening, so you might be still missing quite a few patients. I don't know if you had discussed that.
Sorry, can you explain the question more?
Yeah, so when we do the test, we'll look at this, how sensitive the test is for detection of the condition, and how specific it is with finding false negative and false positive.
Yeah.
So ABI in diabetes population, there were some publications that sensitivity is pretty low. The specificity is very high. It's like 90th, but the sensitivity and detection of disease or detection or ruling out basically the disease is pretty low. I don't know if you had discussed that to maybe add other modalities of the testing.
Yes, I think that has come up. We haven't discussed that into detail, but going forward, as we have a high referral rate, I think we also had some that had results that were like indeterminate, and we want to look into those patients that had indeterminate results and see, what the issue were in relation to, them having diabetes. And, going forward, we also want to figure out whether, there are other tests or something that we can do to help them in relation to the PAD.
Great, thanks. And another quick follow-up question, because I assume all those individuals were completely asymptomatic when you screened them. Did you encounter any issues with the insurance coverage for the test?
That I do not know. I don't know if the team has anything to add to it. I don't know if you guys have anything to add to the question.
Sorry. One of the things that we're looking at is getting better testing devices. So getting a better machine to do the better ABI testing. We have a basic machine, as you guys all could see in the picture, but we're working on getting some better funding resources to assist us with getting some better devices to help us with some of those results. So we're not referring almost every patient to vascular.
Great, thank you so much for excellent talk.
Hi, Nana Jones. I'm pediatric, so we don't do this at all. But there's been some increased surgeons of wanting to do foot screening in our pediatric patients, especially since we now have a growing type 2 diabetes population. And so I was actually intrigued by your flow sheet that you had. Did you create that as a result of this project, or was that already there? As some opportunities to potentially build this type of screening flow sheet for just general kind of foot exams for a pediatric.
Yeah, so we actually built it. We did the blueprint and then we sent that to our IMT team for them to build it for us.